European Perspectives is here today at the European School of Oncology Breast Cancer in Young Women Conference with Professor Olivia Pagani from the Institute of Oncology of Southern Switzerland. Professor Pagani, thank you for joining us today. As an increasing number of younger women are now surviving breast cancer, a growing number of them rightly place fertility and pregnancy issues high up on their agenda. In 2011, you published a survey of reproductive health issues in young breast cancer survivors. What were the main findings of this study?
So the paper was thought to try to set the scene for further research in this topic, because we have lots of retrospective data, but we do not have any prospective and randomized data. And so within the big and the North American breast cancer groups, we decided to make a review of all the data available to set the scene for this important issue, which is still a taboo for many oncologists and gynecologists and professionals who take care of these women. And so the major finding is that women are worried about fertility and the possibility to become pregnant after breast cancer. And so we have to address this issue when talking and when planning treatment with our patients.
And can we start to act on these findings?
I think we have lots of information to tell women that pregnancy after breast cancer should not be a taboo any longer, so that they can consider to become pregnant after breast cancer. We have still many information missing, but the most of the information we have is reassuring about the risk on becoming pregnant after breast cancer. And so we know that it's not detrimental for their prognosis, and it could be also protective. And so this is the first step, and that we have to take care of their fertility very soon after they have been diagnosed. And so we have to deal with this issue when planning the treatment, because many of the women, the young women with breast cancer nowadays, they didn't even think of their reproductive life, because they were thinking of their professional career, of other things. And so many of them have breast cancer before even considering if they wanted to be a mother. And so this is the issue we have to face most of the time. And we can reassure women. They can think the two things are not one against the other, so they can think of becoming pregnant. We don't really know when after breast cancer it's possible to get pregnant. So we have to study, we have to invest efforts to try to sort out which is the best way to preserve their fertility, to take into account all the issues of their disease, but this can be done.
Professor Pagani, you mentioned that the paper that you published was a retrospective study, and the Breast International Group are big, and the North American Breast Cancer Group are now conducting a prospective follow-up, and I know you're playing a key role in this initiative. Could you share with us what are the main aims and expected outputs from this study?
So we are now planning, and it's since 2009, that we are trying to design and to conduct a prospective randomized trial to answer all these questions which are still pending. Now we are planning a feasibility trial in women with endocrine responsive breast cancer to try to sort out how long they should wait before considering pregnancy. And so now the first step is that we are surveying women, and we are asking women who are receiving endocrine therapy if they would like to be randomized into a trial addressing the issue of stopping endocrine therapy after 18 months or after 36 months to allow pregnancy and then resume treatment up to the 5 years. And so to see if early stopping of therapy or longer therapy influence the rate of pregnancy. And so this is the first step. The bigger trial, which of course will be done if the first one is successful, will address disease-free survival and overall survival. But this will take longer and a huge amount of women, and so we need really a global effort to be able to run this trial. Now, there are 26 investigators all over the world interested in the project. And so we are quite confident that at the end we will succeed, but we are just starting.
Sounds like a very interesting study and a very interesting trial. Addressing reproductive health issues can be emotive, particularly in the context of cancer. How do we address this issue in an informed but also a sensitive manner?
I think this can be very difficult at the beginning because you face a woman with a diagnosis of breast cancer, and then most of the time they are interested, of course, in treating breast cancer. And so they say, well, you do whatever you have to do, and we are not interested in pregnancy. But then they realize after 2 or 3 years that they missed the opportunity. So I think it's in our hands to try to understand who are the women interested in having children and try to give them the information. So it's possible now to have fertility clinics to address women to fertility experts and to give them breast cancer is never an urgency. So you can give women the time to think of it, the time of planning, the time of finding the best solution to preserve fertility according to their disease, the need they have to treat their disease. But we are never in a rush, so we have time to discuss these issues with our patients and to address them to specialists who can counsel them in the right way.
And are there guidelines at the European level to help? Because obviously this issue of trying to preserve fertility while obviously achieving optimal quality cancer care.
Just this week it has been published, the USOMA guidelines for young women, and they have some guidelines for this topic as well. And so I think this is a good tool because many of the oncologists, many of the gynecologists, they are scared by themselves. And so they do not address these issues because they do not feel confident, they do not feel at ease. And so these guidelines could be helpful for them just to say, well, it's not forbidden, you can talk to your patients of pregnancy and fertility, you just don't need to think of just of the tumor, but of the person and of the, whatever it's a priority for your woman.
In relation to fertility preserving approaches, what are the approaches we currently employ for young women with breast cancer?
So you have different tools, and some of them are more efficient. Others are still quite controversial, like LHRH agonist to give to women during chemotherapy. And in this setting, many oncologists give these kind of drugs, but the data are quite controversial. The most efficient is the embryo preservation. This, of course, has some limitations because needs some hormone stimulation, which can take 1 month or something like that, and so can postpone chemotherapy. And then you need to have a male donor of a partner. And so this sometimes, and to freeze embryos in some cultures and religious cultures is not as easy as can be. And so, but this is the most efficient way. Other techniques, such as freezing eggs or freezing ovarian tissues, are developing, but they are still experimental. And so you have to inform your women. So the fertility clinic has to inform the women of the available tools, but also of the possibility of success. And some of them are easier, like giving a HRH agonist. Some of them are most difficult, but there are plenty. And so each woman has to sort out what's good for her. And once again, there is enough time to think of it.
Finally, here in Europe, what do we need to do to provide the best quality advice and support to young women in relation to fertility, pregnancy, birth, and breastfeeding following cancer therapy?
I think that the best way is to treat women within a breast unit, because there you have all the specialists, you have psychologists as well, you have fertility counselor, you have gynecologists, and all of them are dedicated to breast cancer, because this, I think, is the major issue. You have to counsel women, but the people who counsel these women has to be dedicated to breast cancer. Breastfeeding, for example. Many gynecologists discourage breastfeeding, but this is not good, because you can breastfeed. It seems to be protective. You can breastfeed from your treated breast as well, or you can breastfeed from the controllable breast. And so, but this you need to discuss these issues. You need a specialist, and so you need a dedicated team.
Professor Pagani, I'd like to thank you for what's been a very interesting interview in an area of increasing importance to young women with breast cancer. Thank you very much indeed.
Thank you to you.